Sir, the slides have
Hello.
started.
Yes, speaking. Sister. Who is speaking? जी बोलो. बढ़िया चालू हो गया है, ये 50 लोग बैठे हैं. बोलो ज्वाइन करो यहाँ. बोलो डॉक्टर.
well protected, very well protected. And thereafter, all immunoglobulins wash out. Their half-life is 3 to 6 months, and everything goes away. Then baby has to develop on their own. But luckily, babies who are breastfed, that breast milk immunological factors protects them from respiratory infections and from GI infections even up to baby is breastfed. But large volume of milk comes even up to 1 year. They are very well protected. They are very well protected. Can you hear me? Sorry.
So we can hear you. Yes, sir.
Yeah. They are very well protected. So that's why this breast milk induced antibodies, transplacentally transmitted antibodies protect the child up to 9 months to 12 months. After 9 to 12 months, they have to produce their own antibodies to fight with an immunity. And how do they produce their antibodies? By experiencing with infection and exposure to infection. So that's why they are more frequently fall sick from 9 months onwards. And exposure of the child also becomes, once if they get exposed to infection, they have to produce their own antibodies to fight. So respiratory infection, GA infections are very common between 9 to even up to 2 years. Every infection builds up their antibodies. Every infection builds up their antibodies. They are, by at the end of 2 years, those who goes through the natural exposure, they are very well immune. In higher socioeconomic class people, they are protected so much even up to 2 years, and they have no natural antibodies. They develop antibodies once if they get exposed during school life, and then they develop antibodies. Otherwise, in a middle class population, low economic, socioeconomic, almost all of them, they developed a good antibodies by the end of 1.5 to 2 years by getting exposure and experience with infection. And today's talk is not adolescent, but still I wanted to highlight one point here. In adolescents, what happens between 12 to 18 years? As all of us we know, there is a immunocompetent state. That means we have a good immunity. And immunocompromised state means your immunity is low, acquired or congenital. There is a condition called, there is a general terminology what we use between 12 to 18 years, immunoimbalance, that is between the immunocompetent and immunocompromised, is a condition, is a general status is called immunoimbalance. They also go through a lot of infections between 12 to 18 years, and atypical infection, very rare, uncommon presentation of common infections, all that phase we'll talk completely in different class. But today I'm talking about up to 2 years. So as a physician, as a family physician, we should understand there is a little sensitive age, imbalance age between 6 months or from 9 months to 15, 20, 18 months. And that stage we have to protect them, we have to educate the parents on how to prevent infections. Now coming to the infections, what all you must be coming across routine infections in your practice? What infections we come across? Only respiratory and GI and some skin infections. So I'll not ask questions, but I'll just describe why these infections are common in children. Now, for example, if you have these two infections, okay, respiratory and GI infections are very common. The reason is mm, uh, only these two, these plus one, that's the skin system. These three systems in our body is exposed to the environment. What we eat, what we drink, everything is like goes through the GI tract. If it is a contaminated, we get infection. And respiratory, what we inhale, what we get exposed to the pollution, everything goes into the your windpipe, and you get infections in the respiratory tract system. And the skin is routine. While playing ground and here and there, we get some rashes, some allergic irritations, and some fungal infections. All these are common. Definitely, if you recollect in your practice, children comes to you only with these three kind of infection: respiratory, GI, and skin exposure. Why not other systems? They don't get infections. For example, you have central nervous system, you have hepatobiliary system, you have nephro kidney bladder, and you have musculoskeletal. You don't get infections. The reason is these all other systems are not directly exposed to the environment. Our only systems which is exposed to the environment, we get a frequent infections. Those who are well protected, your brain is well protected with the skull bone. There is no direct contact with your airway. So that's well protected. Hepatobiliary, kidneys, everything is well protected. This is a very simple logic. These systems doesn't get infections, and systems which get infection is exposed system. Okay, overall, just to review, first I told you that immuno imbalance age, that is 6 months to 15 months, and 12 to 18 years. Uh, Other thing which I told you, the infection what we get is the environmental infections, which is exposed to the environment. That is second. If you keep these two concepts in mind, it becomes easy for a clinician to handle them and console the parents, and need not to worry. Every parent come to us in practice, मेरा बच्चा बहुत frequently बीमार पड़ता है, इसका immunity को बढ़ाओ. And now if you ask why frequently falling sick, what is this infection? Suppose if he gets infection with a respiratory system and GA system, it's not immunologically, immunity is not down. If you get infections in a close protected system, that means your immunity is very down.
Sir, your slide is not moving. Your slide is not moving.
Yeah. I'll move. So this. I'll just move, sir, because I wanted to give a before coming to that. I'll just share.
Okay.
So this is a system. Now, once it is once this is a very well protected and this is system. Now, parents will ask us routinely why this is our baby's immunity is low. Immunity is not low. If you get infection in your GI, respiratory, and skin, it is exposed to the environment. That's why these infections are not a low. It doesn't indicate a low immunity. It's a normal expose. If you get infections in a closed system, then your immunity is low. Now, coming to just for a respiratory infections. Whenever there's always as a clinician, whatever infection we come across, whether we can manage on OPD basis or we need hospitalization. For example, airway is important canal, which he has to maintain his oxygenation and carbon dioxide. Any child who comes with the respiratory complaints, what all, each system has only 5 complaints. Okay, respiratory system, we have sneezing, running nose, throat pain, coughing, breathlessness, and cyanosis. Only 5 symptoms. No other system, no other complaints. Now, clinician, we have to judge in the 2 minutes consulting room. We have to judge this patient is manageable or simple, non-serious or serious patient. If you have any danger signals, what we say is the red signals in practice. In every complaint, red signals we have to pick up and immediately do the needful for that given patient. Now, for example, out of these 5 symptoms which I told you, what all red signals in this? One is a cyanosis, second one is a respiratory distress, breathing heavy, retractions, child is restless and cranky. If these two complaints, if you see, chest retraction and heavy breathing, cyanosis, this means these are the red signals in your respiratory. That means child is in failure. You don't need to go about the oxygenation and carbon dioxide and everything. If we have a small finger pulse oximeter, we can just put it and just look at the oxygen saturation. You can find out whether oxygenation is less or not. But with your experience, with your eagle eyes, you can just find out by looking at the child how much is the respiratory distress, and plus looking little dusky blue. Always keep in mind, whenever we see red signals in this system, keep a pulse, have fingers on the pulse rate at the radial artery. If you find the pulse volume is little weak, or sometimes it's difficult in children who is crying, if you are unable to find that time, that also is an indication that it's a weak, difficult to find a pulse. That means he needs to be hospitalized immediately. You don't need to wait for that. Rest all theoretical. Oxygenation failure, carbon dioxide failure, and respiratory failure is theoretical. For a clinician in a clinic room, in consulting room, only two symptoms in respiratory, you need to admit the child and refer the child to the center. And every complaints, the three things remember in a consulting room. One is that by the time when we examine, it's different. But onset, duration, and progression of symptoms. Every complaint may remember these three basic words which we have learned during first year of MBBS, is like a onset, duration, and progression of symptoms. Suppose any symptoms which has suddenly appeared, rapidly progressive, and is worsening with the symptom, that means this is just not going to give us a time. For example, child has developed cough in the morning, afternoon tak he is breathless and he is dusky. That may be few hours, rapidly progressive. Onset, duration. Duration is within few hours. Onset is rapid, rapidly progressive, and worsening symptoms. Whatever is the symptoms, that means you can anticipate this is going to go down in next few years, few hours. We have to be more alert and keep the child under observation with whatever is required supportive care. In the respiratory system, and right from nostril to the base of the alveoli and interstitium, any airway can get infected, but in that we need to differentiate between these two, upper airway and lower airway. Upper airway, for example, is just above the epiglottis is upper airway, thereafter everything is lower airway. And lower airway is a breathlessness and coughing, upper airway is a noisy breathing and a running nose and throat irritation and pain, and sometimes respiratory stridor. And which I told you, and we don't need to go in detail about theoretical, but practical points I'm telling for clinicians, family physicians, how to pick up the simple complaints and differentiate between whether there is serious and non-serious. What are red signals for the practicing family physician to pick up in each system, which I already spoke about this. Any symptoms presenting with fever is an infection, and any symptoms presenting without fever is a non-infection, most likely allergic mechanism. For example, typical asthma. They have a breathlessness, they have a cough, and they have heavy breathing, but to start with no fever. That means something allergen which is irritate the airway. They have developed all lower respiratory symptoms like a bronchospasm and without fever. That means there is no infection. So clinician can judge whether it is an infective onset or non-infective onset, allergic onset or non-allergic onset, whether it is upper airway, whether it is a lower airway. Upper airway symptoms which I told you, lower airway symptoms I told, and red signals. But always keep in mind, whenever we have first 2 years of age complaints like this, underlying what is basic growth of the child. Suppose if you see a child who has malnourished, not breastfed, birth weight was very low, and unimmunized child, and he used to get this kind of frequent infections with a more severity in the past. Keep these 5 findings in mind. If you find this kind of virtues, that means their inherent strength, that means inbuilt strength, the sustainability to the infection will be very low. Suppose if you have a good nutrition child, well immunized child, breastfed baby child, appropriate for his age, good weight and height, so same infection he can sustain well for 3 4 days, 5 days. And if you have a child who is all not there, 5 thing which I highlighted, so they can't sustain. The infection is same, the severity is same, the host is different. They usually go down within 24 to 48 hours. They go down. So that's why this also is a clinician can judge and keep be prepared and take decision in early, just to prevent worsening at your clinic, at your daycare centers, or even in non tertiary centers. There are different conditions which upper airway we have croup, that is acute laryngotracheobronchitis, pharyngitis, otitis, tonsillitis. These are the things which you come across. In lower respiratory, younger the child, bronchiolitis, bronchitis, pneumonia, this kind of infection. And I don't need to go in detail about respiratory rhinitis and other condition. And treatment, for example, initially we know that in practice we advise medicines and gives away, but in pediatric practice medicine is a second line of treatment. Always remember the supportive care, parents education for little bit, and nutritional status, and then come to the medicine. Your prescription should have first what is nutritional status, how to manage. Suppose if he's distressed, coughing and everything, he may not be able to eat, but definitely bachus can drink liquids small quantity more frequently. If baby is breastfed, he may avoid soft diet 8 10 months. He may not eat, but breast milk definitely bre- breast milk definitely he is going to consume. So definitely advise definitely bachus, when you are parents are coming with the child under 2 years, always start your prescription or advice right from nutrition and plus supportive care for given symptoms. And then if he is on anti-allergic medicine, just ask them to continue, do not stop any chronic medicines. And the fourth one is just start some symptomatic relief and plus specific medicine. For example, if you have any airway problem, whether it's upper airway, lower airway, ask parents to keep baby in upright posture. They feel better. The parents must be coming across to your clinic by saying that my child lap mein hi rehna chahta hai. Yeah, definitely he is in upright posture, he feels better. Even in lying down posture, if you keep him at 40 45 degrees angle, any respiratory congestions, they feel better. And the second thing is you can provide a steam inhalation with electronic steamer, not with the hot water bowl, because that we see a lot of accidents. Electronic steamer, or you have saline simple nebulization. Nowadays, saline nebulization is available at every place, and we can just advise either this any respiratory, just to thin down their secretions in the airway, whether it's a nasal, whether it's a throat or lower respiratory. If you keep a nebulization, saline nebulization, or sometimes hyperneb 3% saline also we get it in the market, that also 6% also we get it, that helps to have a mucolytic effect on the secretions. Or simple steam inhalation at home with electronic device or propped up position. And if child is wants to vomit, don't give any medicines to stop vomiting, because children up to 6 years, even up to 8 years, whenever they cough, they swallow the sputum and they swallow the infected secretion. Stomach is upset, and they pass it out either by vomiting or by in the stools. So do not give any anti-emetic medicine, because let after vomiting, this is the only vomiting which relieves them greatly. After vomiting, if you ask them, their child looks greatly relieved and he's more playful after vomiting. So that's a good, they have removed whatever is accumulated in the stomach. So that one we have to keep in mind. And upright posture and simple nebulization or steam inhalation are symptomatic relief medicines like paracetamol. Or if you have a wet cough, some wet cough syrup, or if you have running nose, lot of running nose, then running nose medicine. And the rest in bigger bachus, there's a different analysis, multivitamins, and other thing which is not important at this stage. You can avoid all those things, but fluid and hydration we have to maintain. If it doesn't drink enough fluid, then dehydrated, every secretion become thick and starts blocking the airway. Then we develop complications of a primary illness. So we have to take care of that. And coming to the antibiotic, if you want to have a successful practice, okay, all of you are seniors, you know, but youngsters must be attending definitely, and always choose a right age of right time of introducing antibiotic for any illness. Most of the respiratory infections, as a standard rule, is viral. Okay, out of 10 patients, out of 10, 100, if you take it, only 3, 4 patients must be a bacterial, otherwise many of them are viral. If you start antibiotic from day one, by that time antibiotic time is coming to stop, 5, 6 days, this viral infection will turn into bacterial, and the bacterial, that time we are stopping the antibiotic, then we are nowhere. अरे बाबा इसको तो antibiotic दे दिया है, अभी हम लोग और क्या कर सकते हैं. But antibiotic गया था तब when there is no bacterial infection. So always give symptomatic relief medicine. Be in touch with the family. If fever, instead of showing downward trend, onset, duration, progression, these three things, basics MBBS. And if you see this is worsening on day 3, day 4, then he needs bacterial cover. That is a secondary infection he is developing on top of viral infection. Then we need to cover with antibiotic. If you start antibiotic at that stage, then you see a response within 2 days. Great. That's what we have to do in practice. Early starting of practice is completely wrong, and we lose that phase of real, and plus we develop resistance. Whenever you have a child with same simple respiratory, as a clinician we have to be more alert to see what is the complications of the primary disease. For example, I have mentioned here few. One, you have respiratory infections or allergic infections that can cause sinusitis. So don't miss sinusitis by pressing at the maxillary and plus frontal and sphenoidal sinuses. If you have tenderness, and then remember, under 4 years of age, sinuses are not well developed. If you have a bigger child, always keep that in mind. Recurrent infection, child is excessive cranky, don't miss that infection has gone down to the middle ear compartment. That's why they are very cranky, they bang the ear, and Bachu is not slept overnight. That means he needs some immediate pain relief and some decongestant medicine and SOS if required antibiotic. And then we have a more the otitis media, sinusitis, and plus we sometimes we have mastoiditis with a facial nerve palsy. All that we have to keep in mind and needs antibiotic. Means as a clinician, we need to differentiate viral, bacterial, and primary disease with the complications. Primary disease with the complications means you have to see the airway, this one, this one. Suppose if you have asthmatic child, his retraction, chest, heavy breathing, you have. But bilateral wheezing, bilateral findings tells you it's only wheezing. Suppose asthmatic child coming to you regularly, someday he looks very toxic, and unilateral findings are more on the chest. एक side में wheezing के जगह पे more of crepitations, and breathing is heavy, and his fever is very high, which is not supposed to be in a wheezing child. That means he's developed a complications of the wheezing asthma. That means there's a mucus plug which is blocking and causing consolidation or collapse of the lung, and developing more respiratory distress and plus dusky cyanosis, which at least we can pick it up by pulse oximeter too. Always better keep one small pulse oximeter at clinical practice. That will guide us and help us to have a early referral. Pharyngitis is simple. Always do not face. Whenever child cries, just put a torch and look into the TA. Whenever we have a generalized redness in the throat, it's a viral. When we have a focus localized tonsillopharyngitis, you can see the white spots, pustular white spots on the tonsils and the pharynx. Sometimes you see a herpingina red spot, which is viral. And sometimes we see a retropharyngeal bulge, that is a retropharyngeal abscess, that is very painful and very high fever. I can see you the photos. One of the photo on the right down, we can see a white patch on the backside of the tonsils. If you see upper photo, that's a generalized redness. That is a viral. The down photo is the bacterial. Which I told you, there's a lot of upper airway infections and tonsillitis. We have to treat accordingly. Simple, the best antibiotic still today, which can penetrate into your respiratory system, upper respiratory and or ear canal, middle and inner ear, and plus your lower respiratory still is a first generation of cephalosporin, and plus you have simple amoxicillin is a still better, good penetration with less uh, resistance. Most of these viruses nowadays, you must be seeing the lot of viruses which is coming in our practice: influenza virus, para-influenza virus, RSV virus. All these viruses been there, but now the test kits are available. We started doing it. Each test cost you somewhere around 8,000-9,000 rupees. No point. As a clinician, as a family physician, you need to whether it is a complicated viral or simple viral. And suppose if you find a complicated virus, you can even add uh, antiviral medicines, oseltamivir, and plus that is called fluvir. And instead of investigating, which is almost expensive, almost 8,000-9,000 rupees throat swab to find out influenza. Every child who has a cold, we don't need to investigate, because most of this infection, we should explain to the parents, is a self-limiting illness, 3 to 5 days. Suppose if you don't see a self-limiting 3 days, instead of showing a downward trend, if it is upward trend, parents are worried, and then we can give a choice that we can document. At the end of it, the treatment is not going to change, because as a clinician, already you have started an antiviral medicine. Bachuska language is only one, more cranky, irritable, that because of heavy headedness, throat pain, body pains. For all that is only treatment is simple paracetamol. See here white patches on the tonsils and everything is a very superficial patches. Along with that erythema and duration, everything we can see. But even these patches are seen backside of the pharynx. So this is a laryngotracheobronchitis. They come to you early morning or midnight into the casualties, because they have a severe inspiratory stridor. They have a croup type of presentation, because they are narrowed, congested windpipe, and it is more severe symptomatic during night phase, and largely it is bacterial. Mostly it's viral. Bacteria is very uncommon. Is a self-limiting. It settles down in 2 days. Noisy breathing, hoarseness, and barking cough. Okay, these symptoms is good enough, and inspiratory stridor. This also is a seen epiglottis that you can see with the torch or little indirect laryngoscope, that will tell us about the redness of the epiglottis. So this is a position typical for epiglottitis. They want to keep their airway patent. So what he's doing is keeping mouth open, little forward neck position. This helps to have better airway. Pertussis, all of us we know, we said the barking, dry nature cough lingers for more than 2 3 weeks. That means you need to start some macrolides like azithromycin and small dose of steroid to control the severity of the cough. These all are like a theoretical. Running nose, outburst, then cold, cough, it is not required. But any viral infection in the airway is a 1 to 2 weeks illness. Initial most symptomatics and more severe in first 3 days, and thereafter less severe. And antibiotic, we had to consider simple either amoxicillin or simple azithromycin. Previously, we used to use erythromycin, but the simple less dose, single dose, and short duration azithromycin is better. And along with that, do not forget about primary drug, that is a penicillin group, that is the amoxicillin and co-amoxicillin combination. These are the bacteria which is always Streptococcus pneumonia, Staph aureus, and influenza. Otoscope in your practice is always better. It just helps us to see at the eardrum, look around any redness, bulging eardrum, or pustules, or furuncles, or auditory ear canal, erythematous, all that we can find out with a simple otoscope. Now, otoscopes connected to your mobile screen, otoscope connected to your computer lab, all that are available now. It's a fancy, it's a very good one. We can take photos also and show it to the parents. They will be more happy. All the treatment is, do not forget, if every symptom settles down in 3 days time, that doesn't mean that we should stop antibiotic in 3 days. Always keep a course of minimum 7 days course of antibiotic and symptomatic relief medicine as long as child is symptomatic. If symptoms are better by 50%, you should stop your symptomatic treatment. Rest 50% naturally they get all right, unless until child is asthmatic, wheezing, and allergic child, he may take little more time to recover. But for that given child, we have to advise simultaneously but exposure of different pollutions at home. We always contribute that airway irritation, allergens are from outside, because we travel to the school and uh, play in a school ground, all that causes a lot of pollution. Classrooms are dusty, AC classrooms on fungal sports, and I think the environment is bad. We can't change. Traveling to school is must. We have to go either bus or vehicle. But thing is, exposure duration during this time is only 15-20 minutes. Even if you place in a ground 10 minutes break, 15 minutes break, our traveling time is in the bus is just 20-30 minutes. Imagine the pollution outside is highly concentrated pollution, lot of dust, but exposure duration is very short. At home, we have very less pollution or no pollution, hardly any. Suppose compared outside is pollution is 80%. If you take at home, it's only 3%, 2%. But duration of exposure at home is almost 20 hours. For a kid who is 2 years, not even traveling outside except play school. People starts very early in life. Play schools. The exposure in play school is just 2 hours. Nothing, everything is clean, but going here and traveling time is exposure is short. But exposure at home is almost 20-22 hours with a less concentrated pollution. For example, what are pollutions at home? What are environmental challenges at home? One is dust, smoke, strong smell, kitchen smoke, agarbatti, and talcum powder, perfume, fur type of blanket pillow covers, pigeons in window, pets at home, and soft toys around, carpet, sofa, curtain dust. Okay, fungus on the wall, AC filter has lot of fungus, plant pollens, many things which irritates at home. Very minimum, but duration of exposure is 22 hours. So before you pointing out to the environmental outside, which we can't change, we have to face, always keep his surrounding at home better, then we see a major improvement. Sometimes in practice, if you come across why this child is not improving, in spite of taking care, in spite of advisors, reevaluate. Your medicines are good, everything, but child lifestyle has not changed. Eating bad, eating colored drinks, colored food, thanda, khatta, meetha, and exposed to different environment, pollutions at home. They educate the parents and listen to them, and writing a second medicine, third medicine, fourth medicine is not going to help. Remember, in pediatric practice, 1 2 medicine which has not helping the child, third medicine never helps, never shows improvement. Is a dictum standard. 1 2 medicine fails to control, third medicine is not going to help. That means we have to reevaluate, go back to the primary basic onset, duration, progression, and again the lifestyle, and advise parents, educate the parents, exposure system, supportive care system, everything. ऑलवेज हरी भरी चलो ये काम नहीं करता, दूसरा मेडिसिन दो, दूसरा नहीं रहेगा, तीसरा, तीसरा नेवर एक्ट्स. And remember all pneumonias, respiratory infections, lower respiratory infection, which I already told you, and we need to admit you have a cyanosis, flaring, and grunting. All that symptoms, you have to be careful about those symptoms and treat accordingly. And always, pneumonia needs, before it goes into pneumonic complications, is injectable antibiotic. And we have to explain to the parents that medicines are same for pneumonia, but only thing the dosage, injectable dosage is 3 times higher than what we use in a simple amoxicillin. What we use is 30 mg per kilo. In a practice, oral medication, same amoxicillin, we can give 100 mg per kilo, which takes care of lower respiratory pneumonias. Which I am not going to go in detail, but X-rays. But thing is, for a clinician, upper airway, lower airway, we need to differentiate. And there is a old still cotrimoxazole which we hardly use, because again it has effect on the bone marrow, and that's why we avoid cotrimoxazole. That is you remember, it's a Septron, which we use it in some atypical infections, but not as in routine practice. Some of the is still the better. Now coming to the diarrheal diseases. Next system, which I already told you, GI system. Now coming to diarrhea, dysentery, increased gastric motility, vomiting. As I told you, in the respiratory system, we have 5 complaints. In a gastrointestinal system, we have again the few symptoms. What are those complaints of patient? Nausea and vomiting, loose motions, constipation, correct? Loss of appetite, which happens in many other, but not specific to GI, but vomiting, loose motion, constipation, tummy pain, abdominal distension. Okay, only these 5 complaints about GI tract. I'm not going to go in detail about hepatobiliary and kidney other, but coming to these common infections, what we have come across, GI. Out of that, we have to judge and decide always. If you complaints patient, then always think onset, duration, and progression. Suppose diarrhea and dysentery, how will you differentiate? Diarrhea is a watery loose motions. For different age group, different day. But if you have baseline motions, say compare kare, if he is passing more voluminous stools, little more frequent stools, that is diarrhea for that given child. We don't need to remember these numbers. Less than 6 months, above 6 months, this is very difficult for a practicing pediatrician too. So diarrhea. Dysentery means you have a small quantity, sticky, mucousy, little red or black spots in the stools. Motions are hardly any, lot of cramps in the tummy. Diarrhea has lot of less cramps and more watery diarrhea. So we have to, whenever patient comes to you with a diarrhea, what is only few symptoms: abdominal distension, abdominal pain, constipation, loose motion, vomiting, nothing else. Okay. Now, how will you manage these patients? 8 out of 10 times, when you see a watery diarrhea, it is viral. Dysentery, what you come across is a mucousy, sticky, is bacterial. That's simple. If it is related to high fever, that means is infection. If no fever, that means is a gastrointestinal irritation to your food. Eating some colored drinks, colored food, or allergic irritation can produce. So the hyperosmolar foods can produce diarrhea and the stools. For example, if bachu eats lot of heavy sugary food, and that is hyperosmolar. He may pass 1 or 2, 3 stools. That doesn't mean that it's infection. So simple to differentiate in every system complaints के साथ, whether it's a fever or without fever. Now coming to GI, it's a watery diarrhea. It is a mucosal stool, small quantity. Tummy cramps means your germs are adherent to the intestinal mucosa, which is causing irritation to the intestinal wall inside the lumen, and that causing a cramps of the intestine. Muscle goes into spasm, smooth muscle. The spasm, they get a pain, lot of pain, severe, and then relaxation. So that means they relieve that symptoms. Intermittent pain, tummy cramps is that related to GI, gastrointestinal infection. So now that jumps which is adherent to the intestine produces the cramps. If it penetrates, causes more damage to the intestinal mucosa, then it causes melena or blood in the stools. And lot of mucus, any irritation to the any system. For example, you have nose irritation, you have thick nasal discharge. You have eye irritation, you have lacrimal system. So like that in intestine, if you have irritation, then you have a mucosy stools. And plus on top of mucosy stools, he has even watery diarrhea. That means without mucus, without anything, that means diarrhea is germs are going into the lumen. Your body system is not allowing that germs to stay and get adherent to the intestinal wall. That means your germs are just going inside. Your body immunity is very good. You are throwing away those germs by passing extra stools. So that is a very good sign. Whenever we have watery diarrhea with a less cramps, with hardly any fever or fever bhi aata hai, in one day it settles down. That means your system is very good immune system. Its germs are not trying, is trying to get adherent to the mucous membrane, but you are producing lot of fluid and washing out those germs by passing watery stools. That is a good immunity. That's what you have to explain to the parents. And now the hydration is the only thing which we have to maintain. Many times with all these kind of watery diarrheas, we lose our body fluids and electrolytes, dehydration, hypotension, and then issues, especially in areas in India where summer and lot of hot, already you are exhausted, and that causes dehydration and shock. Your job is only to replace fluids and electrolytes. Standard way of preparing a ORS solution at home. In Mumbai city you get it, but even in rural areas you can advise 1 glass of water, that is 200 ml, and 1 pinch of sugar, and with the 2 fingers and thumb, that is a sugar, and 1 finger and one thumb is a salt, is a preparing at home, is a simple that we can go on giving sips. And usually God is kind, vomiting never lasts beyond 12 to 24 hours. As soon as vomiting stops, then they start passing loose motions. Whatever is they are passing in the loose motion from the down, you can replace it by giving fluids by mouth. And largely in acute condition in practice, we see viral, bacterial, as I told you, mucocystic. We need to treat different types of bacteria. We don't need to worry about type of bacteria. Most of these they respond to many antibiotics. Simple. You have third generation cephalosporin. You have simple quinolones like a ofloxacin. This kind of group of antibiotics. You have to take care by electrolytes. This child already I told you. Chronic means lasting more than 1 month. Is That's what. Persistent diarrhea means dysentery. It's more than 2 weeks. Remember, anything more than 2 weeks, you need further investigations. Anything chronic, which is definitely needs more evaluation, including endoscopy, because inflammatory bowel disease, what you must be coming across in practice with adults, Crohn's disease, ulcerative colitis, that also is common in children. Anything in spite of antibiotic, in spite of supportive care fluid, electrolyte, if you continue to see bad stools and losing weight, that means, as I told you, red signals in the respiratory, what all red signals in the GI system. anything child is lethargic, sunken eyes, looking more sick within 24 hours of GI symptoms. Peripheries are warm, cold to touch and feeble pulsations, and passing large voluminous diarrhea or stools within, like in front of the clinic may passes or ask mom how much is the volume in each. After passing stools he becomes lethargic. That means he is like a onset duration progression is rapid. He is losing more volume. He needs an IV fluids. And lethargic bachus can't take it by mouth completely. And by the time when they can't take, then they go further down in a hypotensive shock. So you need to keep this in mind. Lethargic, sick-looking child, after passing, he becomes very dull and not active, and volume of the stool is heavy, watery, rice watery, and then you need to admit this child for an IV fluids and electrolytes. Otherwise, if child is playful and active, and eating less, drinking less, but symptoms are going on for 3 4 days, you can manage at home. The most important decision factor for a practicing pediatrician or family physician is important child's activity with any other symptoms. If child is active, that means symptom complaints, whatever infection he has is not so severe and not so bad. And danger signals, so I told you. And other thing is, remember these two words which I have mentioned here: persistent and chronic is more than 14 days and more than 1 month. Even more than 14 days symptoms and 1 month symptoms, even pediatrician needs to refer to pediatric gastroenterologist to do further evaluation, and including endoscopy and biopsy to rule out inflammatory bowel disease. We have this is just as I told you, exposure to respiratory tract is very important. Take care of your exposure in a GI. What is important to prevent pathology is just hand washing, hygiene, because it's a fecal-oral transmission. Proliferation rapidly happens in the intestinal lumen. There's a lot of mucosal damage, which I told you. Always keep in mind in practice any system, any complaints, underlying general status of the child: thin-built, undernourished, chronic illness, or chronic medicines like a TB, epileptic medicines, then on top of it is developing. Keep in mind always that is one negative point, that you need to take care of the child in early phase, not at the later phase, before they go into decompensated phase. When we are treating a child, always keep in mind, I told you, nutritional status, supportive system, then come down to specific treatment and underlying pathology. Don't stop any other medicines. If he is on antiepileptic, if he is on some TB drugs, do not stop all that. So diarrhea and dysentery, which I told you, antibiotic. Coming to, sorry, Dr. Dolikia, whenever you want me to stop, just let me know, because I have many slides.
10 minutes more there.
Yeah. Okay, I'll just finish this. And
Yeah.
as I told you, oral hygiene is just ORT, and plus always encourage and push parents to give lots of liquids. If he doesn't want to eat, do not force, because most of them, when they lose body fluids and electrolyte, they need that replacement. Hospitalization, another thing which I'm not going to talk. Red signals, which I told you, in a GI system. And a few things about other systems which I am going to highlight, which are not made the slides, but appendicitis and acute abdominal in GI is also any severe abdominal pain. Always keep in mind needs a referral. Unbearable pain, when the intermittent child becomes dull and comes back, is intestinal cramps. Severe abdominal pain, looking toxic and tachycardic, that means you need to rule out intestinal perforation and appendicitis. Malnutrition, always you have to keep in mind. nutrition status. I'm not going to go. And skin infections are common, which happens under armpit, around the neck, behind the ear, and diaper area. And most of these infections are irritation or too warm related, and children who repeatedly apply some talcum powder and some creams, which is a good environment for a child, for bacteria to grow there. Always try to ask them to avoid unless until he has. You have to apply in a very minimal quantity in a way that it should not be seen at all. And coming to skin infections are common. Suppose if you start seeing a oral thrush in a child repeatedly, that means there is a some T cell deficiency immunocompromised child. If you start seeing a skin infections repeatedly, that means bad hygiene. It doesn't indicate anything. You need to educate the parents about the proper hygiene. If you are finding every time diaper rash coming, that means you have to take care of the diaper. Standard instruction for parents whenever you are using diaper, as soon as it gets wet, remove the diaper, and once if it passes tools, clean and don't apply the diaper immediately. Keep the child open, exposed to the environment and aeration. If he gets a good ventilation aeration in diaper area, then they have no rash. You suppose if you are cleaning and again giving a new diaper, no exposure to the environment, and this rash definitely will come, because sometimes depends on our food items. Stools are acidic, and stools can irritate the skin. Or there is no exposure. Diaper has a lot of chemicals. Once if it passes stools, urine, all that chemicals gets released from the dry diaper into the outside, and along with the stools and urine, everything irritates the skin. So that is a skin infections. Largely, it's a fungus or injuries which we can apply antibiotic cream. Cold sponging is required whenever you get a call. I got suddenly child fell down, there's a swelling on the forehead or something. You need to console the parents, give paracetamol, and apply ice to reduce the swelling. And fungal infection, just you can treat with antifungal creams. And if you have bacterial infections, then you need to treat with some anti bacterial creams. These are the basics. Beyond that, anything which is lingering, going for a long time, eczematous skin, then you need to take a specialist opinion. Now coming to the genitourinary, very important in practice, though it is a closed system, but in a girls, small babies, the urethra is very short in a females, and the infection is very common. Any fever with no symptoms like a respiratory symptoms, no GI symptoms, no complaints, only high fever in a girl child, unless until we rule out it is UTI, is a standard dictum. Any child who has fever more than 24 hours and no GI, no respiratory system complaints, on examination, if you don't find anything in the throat and ear, if child has continuously high fever 102, 103 with rigors, unless until you rule out, is the standard gold standard diagnosis is only UTI. Ask for a routine urine, you'll find within few minutes you get a report diagnosed as a UTI. And how will you manage this? Most of them they respond to oral medication. You don't need to admit and treat. Simple third generation cephalosporin oral antibiotic. You have cefixime, this kind combination, ofloxacillin, and even amoxicillin also will act. You don't need to rush, and unless until there's a pyelonephritis, lot of abdominal distension and tenderness in the abdomen, sonography shows something. You need to. Most of these are lower urinary tract infection. They respond to oral antibiotic. One infection accidentally it can happen. Recurrent infections you need to refer to the specialist. Why recurrent? Sometimes they have a reflux. VUR. VUR means vesico-ureteric reflux. Means when we are passing urine, is instead of unidirectional, instead of coming down through the urethra, 10, 20, 30% urine goes back to the ureter. After passing urine, they feel empty bladder and they stop. But whatever which has gone up to the ureter and kidney, again it comes back to the bladder. That causes repeated infection. Any urine stays in the bladder for a long time invites infection. So this is the one. This is called VUR. Second infection in the girl child under 1 year, And now one infection in a boy under 1 year demands further investigations like sonography, MCU, and DMSS scans. All those are later on. But for a clinician practicing family physician, what is important is any child presenting with high fever beyond 24 hours with no other GI or respiratory symptoms need to look into the UTI. You just get a routine urine test. In that, within few minutes, you'll get the report. You can differentiate and treat. If you don't see a response to your treatment within 48 hours, child has more cranky and irritable, and child while passing urine frank pus-like thing, if you are seeing, then you need a referral. You need to admit this child and give a good hydration so that once the diuresis happens, then they clear the infection. That's about the genitourinary in a small children under 2 years which come across this kind. Now coming to hepatobiliary system. The symptom of hepatobiliary, for example, you have hepatitis, only jaundice, large liver abscesses we see. Okay, this kind. Anything which child is very cranky, high fever, no other symptoms, loss of appetite, or jaundice appearing, then you need to work up and eat. Hepatobiliary system is a one which is very difficult for pediatricians and family physicians to manage without further investigations. We need to do workup. We need to have a specific treatment. Sometimes most of this viral infection which we come across, hepatitis A and E, is a self-limiting, mild, minor, with no complications. We don't need to even treat. We need a only symptomatic supportive care like antiemetic medicine, fluids, electrolytes, caloric consumption. If they are not eating first 2 3 days, we have to take care of thing. If child is not eating, we have to. This jaundice appearing, child is cranky, we need further investigation and specialist referral. And coming to the systems which always in the standard practice in a busy family practice, always keep in mind when to refer, how to pick up red signals, and these are the things we have to pick up and refer the child at right age and prevent the complications. Always look into the complications of the primary disease. Don't miss out those things while treating. And if child doesn't respond to your antibiotics on day 3, always call them and again examine before you give a referral. And antibiotic usage at right stage of infection, never first 2 3 days unless until you have strong evidence of bacterial focus. Follicles in the tonsils, yes, you can start. If you have generalized throat or something generalized symptoms, you don't need to start an antibiotic. And plus, always do not forget about the treatment. It's not like an adult, chalo antibiotic de do, crocin de do, settles down. No. Nutritional, supportive care, availability, and plus symptomatic relief medicine. The last one is the antibiotic. Remember, any underlying child, underlying chronic illness, like you, those diabetic children, or those obese or undernourished, or chronic medications like homeopathy or yeah, TB treatment or epileptic treatment, chronic, always keep them as a special category patient and be alert before you advise any medicines drug interactions. Take a help of your colleague pediatricians. And I'm not going to go in meningitis now. Coming to GIV talk, biliary, hepatobiliary, respiratory, and nephrology. And coming to brain is only 4 symptoms: headache, irritability, vomiting, seizures, unconscious, altered sensory. Anything which is intracranial compartment, no oral antibiotics will help. Any symptoms, intracranial symptoms which I told you, uh, repeated vomiting, becoming drowsy, peripheries are cold, and very irritable child or drowsy or altered sensorium child is immediate referral for further investigations. And you can see now coming to the skin, as you told you, fungus and always remember, in a practice we come across 2 types of rashes on the skin. One is allergic rash, another one is a viral rash. Remember, viral rash, always most of these viral rashes what we see in the practice starts from the hair margin, forehead, behind the ear, then it progresses downward towards the tummy and lower limbs. Allergic rash always suddenly appears every part of your body and causes a lot of itching. In a viral rash, you have a less itching. In an allergic rash, you have more itching. Allergy rapidly appears your center whole body, and viral rash usually starts with the upper measles and mumps and other rashes. So upper part of the body. Okay. Any questions? So I'm there. Thank you very much for patiently listening.
Thank you, sir. It was too good. You even told us, about why infections occur, what to tell the patients, the parents. It was too
Yeah.
nice. There are a few questions. Can I take them?
Yeah, please.
What are the indications for giving steroids, and what should be the loading dose, and how it should be taken?
Children with steroids, like we use it in acute wheezing patients, asthmatic. You know that if you see a wheezing known case of asthma, you have first time sometimes difficult. Suppose if it comes to you repeatedly, already has taken, then simple, after giving a bronchodilators, if we don't see an improvement within 24 hours, if he's breathing heavy, you can give us oral steroids. Oral steroids are like you get a omnocotil and other medicines, like it's a 5 mg per 5 ml, roughly for a 10 kilos. Okay, 1 to 2 mg per kilo is a 5 ml 3 times a day. That comes to 15 mg for 10 kilos. That means it's a 1.5 mg per kilo per day. For us, to per kilo per day calculations are becomes difficult. For roughly 10 kilos, Bachu is a 5 ml TDS. 20 kilos is 10 ml TDS. In between, you can divide that.
Sir, about weaning, how do you start introducing solid food? And if you think the solid food consumption is less, can you substitute it with milk? And how do you reduce the breast milk? But
See,
hmm.
child weaning, it has to be smooth, and children who are bottle fed and top milk fed bed, we can wean the food even up 4 months. Breastfed baby who's gaining weight and everything, your weaning you should start at 6 months.
Yeah.
Whenever we introduce the three standard principle, you are introducing a solid food. Always remember that you have to introduce everything a pulpy food, not a liquidy food. Okay, and the third thing is you are giving a new taste, introduce everything natural, home cooked taste, not the ready-made formulas like a Nestum, Cerelac, biscuits, and all that. Third thing is they learn how to chew and swallow, introduce pulpy food. The
Introduce
last pulpy one,
if
not dal ka pani, patla soup, patla juice, no. And the last most important, when you introduce the weaning food, bachu learns to be patient, sabar. Suppose if your baby is a bottle fed or breastfed, he's whenever he feels hungry, cries, you keep the child to the bottle or breast, and immediately they suckle and hunger gets satisfied within few seconds. Easily digestible, he has been doing from last 4 5 months, वो हो जाता है. When you introduce a solid food, 1 teaspoon of food in the mouth, immediately it comes to in his mind, what is this heavy in the mouth, different taste, not easy to swallow, digestion takes 10 15 minutes, at the end of hunger satisfaction happens 20 30 minutes. He gets cranky, irritable, he throws tantrum, he doesn't take, and if he doesn't take, then giving back that option of breastfeeding, bottle feeding is a wrong. तो ये मॉम हैज टू बी पेशेंट. सपोज इफ ये बच्चा नहीं खा रहा है खाना करके उसको बॉटल रखेंगे, ब्रश पे रखेंगे, वो बच्चे को तो माइंड में आ जाएगा. सपोज इफ आई डू दिस एवरी टाइम, आई एम गोइंग टू गेट माई मॉम्स मिल्क, बट दे आर स्मार्ट इनफ बिकॉज दे हैव बीन ट्रेन फॉर ओनली मिल्क फर्स्ट 4 6 months. तो वी हैव टू बी स्ट्रिक्ट. हम लोग स्टैंडर्ड इंस्ट्रक्शन पेरेंट्स को बोलते हैं, व्हाट टू गिव टू द चाइल्ड मॉम विल डिसाइड, हाउ मच टू टेक एंड हाउ व्हेन टू टेक चाइल्ड विल डिसाइड, डोंट क्रॉस द बॉर्डर्स. ये बनाया है, ये खाओ.
what are the choking hazards in food, and what is baby-led weaning that is gaining popularity now? Do you believe in it?
Yeah, see, basically, if you standard follow the how much to eat, when to eat, child will decide, and what to eat, mom will decide. तो इसमें choking वगैरह कुछ भी नहीं होता है. If you try to force, try to give more volume each time, जल्दी ज़्यादा खिलाओ, तो उसमें उल्टी करेगा, choking होगा. तो वो choking होगा भी not anything major. They choke and suddenly they get all right within few seconds. During that moment, you have to turn the baby to one side, whatever is going, which comes out. In a healthy babies, we never see complications with choking unless until child is sick.
Okay. So there's a what is F100? Diet
Huh?
F100.
Ah, see, these are the numbers which is given. Okay, and always the diet system. I have a dietic chart. Usually, what I tell parents is like a you have a only four types of food items in your whole list. One is a vegetables, second one is a fruits, third one is a cereals, and the fourth one is a homemade cerelac. Homemade cerelac is a standard. Previously it's called Hyderabad food. Homemade cerelac is a mixture of wheat, rice, ragi, and moong akka green wala. Take 100 grams each and 50 grams of almonds. Wash, dry, roast, and grind and mix all these powders. Keep it ready. Whenever you want to give to the child, take 2 spoons of powder, boil it in little water. 1 मिनट में boil होके thick हो जाएगा. Add little milk. Mom's का रहेगा तो express milk, otherwise pocket milk. Little jaggery as a rich source of iron, and little ghee is a very good source. Homemade celiac it is called. Natural taste, good proteins, good iron, and ragi is the richest source of calcium. So this kind of food items is get. You take it as a this is a F100 and there's a lot of names and everything is given. But natural four items of food is vegetables, fruits, cereals, and homemade cerelac. And the homemade cerelac, four grains which I told you, each is different state has different combinations. In Kerala, if you go almost nearly they add 15 to 18 grains together to make homemade cerelac. It's a very good item, but standard if you prepare with these four grains with almonds, you have excellent calories. Bachus they enjoy this food.
Okay, sir. Sir, name and dosage of medicine and fecal impaction in children less than 3 years of age.
Yeah, so constipation is very common. Any chronic, subacute, intermittent tummy pains in a children is a complete inevacuation. That means child is passing stool 4 times in a day, but that's not a good adequate combination, adequate quantity. He's trying to pass stool small quantity, unable to pass completely. Is a constipation. Child is passing rod-like stools or hard stools or brown color stools, lot of flatters, small quantity of stools is a constipation in a child. Simple laxatives are age old, milk of magnesia. We had that. This we can use 10 kilos ke liye 10 ml, 5 kilos ke liye 5 ml, like that we can use. And other new available is polyethylene glycol. You must be using in adults. The same thing we can use it in children. Is available in liquid form or the same dose 0.5 to 1 ml. And if you are using a powder form for 10 to 15 kilos 1 scoop, and 15 to 30 kilos 2 scoops, 30 to 45 kilos is 3 scoops, 45 and 60 is the 4 scoops. The
Okay.
polyethylene glycol.
So, if there is no fever and no infection, is it still necessary to give antibiotics in case of breathlessness due to asthma?
Yeah, no, you give symptomatic bronchodilator, you start steroids, you don't need antibiotics.
And any place for anti-secretory drugs like enough for watery diarrhea?
No, anti-secretory, suppose if he is passing watery stools, anti-secretory gastric motility reducing drugs is contraindicated. They have abdominal distension and lot of fluids accumulates in the abdomen. It doesn't come out for 6 to 8 hours till medicine effect lasts. Most of these drugs have sphincter constriction effect. Anal sphincter get constricted, everything gets accumulated. Bachus will have more vomiting, more severe abdominal pain because of lot of stools accumulates in the intestinal lumen. We never advise.
So you say no cough syrup in young children. Are Ayurvedic preparations safe?
Yeah, these are well-known products. Like for example, even my bosses used to use Adusol, Tulsi ka base, and all that. Those things are okay, but unknown cough syrups, which has no standard with any field, whether it's a non-allopathic or Ayurvedic, homeopathic, Unani, and something, we don't encourage. You should have a standard brands.
So analgesic antipyretic to be used in a young child allergic to paracetamol with fever.
Yeah. Now, most of this paracetamol allergic is not because of the compound of paracetamol. It is the preservatives of the paracetamol. We see in a practice like सिरप देगा तो उसको रैश आता है, तो टैबलेट को क्रश करके पानी में मिला कर दो तो रैश नहीं आता है. That means the preservative, the orange flavor, mango flavor, all that strawberry flavor, that causes more allergies.
And so you said in girls, like after one UTI, the treatment should be antibiotic should be for 5 days or 10 days with high
10
fever.
days. 10 days. Any UTI, 10 days antibiotic.
And no need of MCU, only for recurrent infections later on.
First infection, you'd have to take care of diapers. You have to cleaning method has to be from front to backwards, not to back to front, and no constipation, giving lots of liquids to pass urine, and local hygiene, and look at the separating the labia minora. Sometimes they have a mucous membrane there which restrict the urethral opening. If you do not have anything, then you need to take care of local hygiene, and if you don't get second infection, you don't need to work up further.
Perfect, sir. All the best.
Child, Madam, sir, child becomes 6 weeks old. If a child is dull, not smiling, not responding to mother, what may be the cause?
So now that the 6 weeks ka social smile eye contact, usually at 6 weeks, we can wait up to 2.5 months in a full-term baby. If you don't see 2.5 months, then is like we have to work up further. Whether associated any other developmental anomalies like a loosey child, hypotonia, hypertonia, reflexes are poor, and not only eye contact, no social smile by 2.5 months. The range is there for every milestone. Okay, social smile anywhere between 1.5 months to even up to 3 months that we can see. In a preterm baby, it may be longer.
Your convulsions below convulsions in 6 months or child.
Yeah, any child, infant, neonatal conversions, we need to work up. Baseline investigations is a calcium, magnesium, ammonia, everything, metabolic workup. If doesn't help, then further EEG and MRI investigations below neonatal. And other infantile convulsions also depends on other milestones. Suppose if he has only seizures, and the rest milestones are normal, sometimes a simple epilepsy. Suppose developmental delay and seizures, that means something genetic and metabolic conditions.
Okay, sir.
Yeah. Give it to her.
Yeah, thank you very much. Now I would like to
Ravindra,
request Dr.
give it to
Ravindra
Ravindra.
Bhargava to give the
Ravindra.
thank you note.
Thank you, Dr. Fazal Nabi,
Yeah.
for the exhaustive and educative talk. We learned a lot about this complex subject of children in a very simple words. That's very nice of you. And I would like to add that about Dr. Fazal Nabi is a highly experienced consultant pediatrician, neonatologist, and pediatric intensivist with over 30 years in the field. He's trained in India and UK. He specializes in neonatal intensive care, complex pediatric procedures, and critical care. Is actively involved in research, teaching, pediatric ethics, and has managed numerous high-risk cases, including extreme preterm, infant, and transplant pediatric care. Thank you so much, sir.
Thank you, Mr. Thank you. I had a nice time, and I've been
Okay,
always.
sir.
Thank
Thanks a lot, sir. Thanks a lot.
Thank you.
Lena, thank you. Thank you. Thank you, Ravindra Bhai.
Thank you, sir.
Thanks. We are very particular. We start sharp 2:30.